Okay, so this patient, a young patient, came in with liver failure. We can see their liver looks enlarged, there's ascites, and then there's this unusual appearance in the right hepatic lobe. The portal vein we can see here, the hepatic artery we can see here. So any guesses about what's going on with this patient? Try to narrow the windows. So Anu says she can't see the hepatic veins, so good. I would say maybe you can see a trace of them here, but that was definitely a concern. Bud Chiari was brought up. This is not, we don't have a later phase right now. We can see that the portal vein is probably patent. Kedar says fatty liver, another guess for Bud Chiari. And then Gitanjali says steatohepatitis. Excellent. So this was actually called, at a different hospital, this was called a hepatic infarction, and they were concerned about Bud Chiari syndrome. They started the patient on anticoagulation, and the patient ended up actually starting to have a bit of a GI bleed. So a couple of things that the audience thought that we should have done was get a later phase of contrast, just really look at the hepatic veins better. So we did do that, and this was the MRI. So here is the arterial phase. I would say you can see these hepatic veins, the left and the middle and the umbilical vein. And there's question, what is this? Is this an artifact? When it's really linear and dark like this actually tends to be more likely to be an artifact. But as we go to our later phase, Olga says you should have just done an ultrasound. True. We did an MRI because we do MRIs and everything. And you can see that the hepatic veins and the IVC are all patent. They are a little bit thin, but they're patent. So that would not be Bud Chiari syndrome. We also have a circumcaudal cava. So the cava is getting kind of squished in with a cauda that wraps around it, but that's normal. The portal vein is also normal. You can see that there's a trifurcation of the portal vein. So anterior, left, and posterior all coming off at around the same part. And we've still got this perfusion or abnormality here in the right lobe. So this was not a hepatic infarction, which is extremely rare, especially when your portal vein and your hepatic arteries are all patent. Excellent. Rubel is asking for the in and out of phase, and that is the key here. So you can see, I can't pull them up side by side, but basically the in phase, the liver is nice and bright. And then the out of phase, the entire liver is fatty, but there's much more severe hepatic steatosis in the right lobe and segment 5 and 6. So this was just severe hepatic steatosis with probably steatohepatitis or inflammation of the liver. It usually, it either can be diffuse, or if you get focal fatty infiltration, it could be along the gallbladder fossa, portohepatis, subcapsular areas. But sometimes it can just be very geographic like this. So on CT, you could be fooled into thinking that the liver is hypoenhancing, but it's actually just fat. If you don't have a good enough phase, always just get a later phase or an ultrasound and make sure that you're not overcalling Bud Chiari. And David Fetzer says this is another good case for contrast-enhanced ultrasound. Good, excellent. So David's going to show us some interesting cases from contrast-enhanced ultrasound next Tuesday. So he can show us how he excludes Bud Chiari if he has one of those cases. Any other comments? Question, how much did that sat out on T2? It's probably getting close to 50% given the CT attenuation. That's true. I don't have the T2 here, but especially when you're getting severe hepatic steatosis, we'll start seeing saturation on the fat sat. Okay, it's 7 o'clock. I will see you guys next time.